Thank you, moderator, and good evening and good afternoon, all the audience. Of course, I would like to say thank you to organizing committee who invite me, especially Dr. Muhammad Al-Amri. Nice to see you all. And then today I would like to share with all of you with the ptosis with a poor left atrial function. I think it's different with Dr. Virus, but I think this is always the challenges for oculoplastic. So I think for the grading of blepharoptosis, I think Dr. Virus already remind us, the poor left atrial function, it means the left atrial function is less than 4, and then the grading for the ptosis is important also for us. Usually, the patient with a congenital ptosis come to us with a moderate or severe ptosis. And here, I think we all know the ptosis. It means the droopy of the upper eyelids more than 2 millimeters upper eyelid, usually covering for the superior limbal. But if it's more severe until covering all the visual axis, it means it's a severe condition with the grading of blepharoptosis. For the anatomical, of course, we already know about 7 layers of the eyelid, and then in the case with the blepharoptosis with the poor left atrial function, of course, we should be managed for the suprabro, or the frontalis muscle. This is the workup for the diagnosis for the physical examination, margin reflex distance, and then the palpebral fissure. That we should know what the height, and the lid crease is very important also. But because we make it the incision from the lid crease, I think the RAS is different. RAS is different height. Usually in Indonesia, usually in a man is height 5 millimeters, and then the woman is 6 until 7. But I think in here, in the Middle East, you have a height contour of the lid crease. And the left atrial function is very important. When we look the left atrial function is poor, it means the function is only less than 4 or 4 millimeter at least. And usually when we wake up, we should be press the frontalis muscle to know about height, exactly the left atrial function. And the eye position is very important. When we work up, the primary gaze is very important because we would like to avoid the change of eye position post-operatively condition in blepharoptosis correction. But sometimes we should know about the eye movement in this patient. Like here, maybe during the COVID, sometimes the patient come to us with covering the mouth. Sometimes we forget. Maybe is there any jaw winking condition? That's why don't forget in patient with a poor left atrial function to know, but is there any jaw winkings or synkinesis retraction between the trigeminal and the oculomotor muscle? And the Bell's phenomenon, I think, is very important for patient with the poor left atrial function if we want to correct it, because some patient doesn't have a good Bell's phenomenon, but usually the Bell's phenomenon is 70% is upward and outward movement, but some of case they have a downward movement, maybe it's around 20% case. But if we have a poor condition what blepharoptosis, I think the undercorrected, sometimes we make it for prevent the exposure of the keratopathy. Of course, in the poor left atrial function, the technique we will make it an incision for the skin crease, and then make it tunnel, and with the sling material in the orbicularis plane, we can use the material synthetic or allograft. This is our patient. We only make it take it the material allograft with the fascia lata, but we only take it about 2.5 centimeter or 3 millimeter length, and then the white rounding 1 centimeter. Then I make it the Y shape condition and suturing the tarsus and going the channel to suturing the front fascia lata to the suprabrow. And here we can use the silicone rod. I think it's more easy if the patient cooperative. Sometimes we did with the local anesthesia. It's maybe only the 15 minutes we can do it, and we make it the 5 holes, of course, two in the slit crease, and then 2 in the suprabrow and 1 in the central. Usually I make it in the central or up. The suprabrow is 1 centimeter. And the frontal suspension, and I mentioned before, we can use the fascia lata. This is a minimal infection, extruded and rupture, and greatly viability and compatibility. And patient usually we can do it in case in 3 years old, but I have an experience in 2 years old kids, because I just take it only 2.5 centimeter and wide about 1 centimeter. That's why I can take it from the children less than 3 years old. And then another material, like I said before, I use it silicone rod, or sometimes we can use the polyfluorine ethylene suture. And from the 2 years, I do with the frontalis flap. I know some oculoplastic would like to know about how, if you use the frontalis flap for can I get 1 minutes more? For minutes the for managing the poor levator function in ptosis eye. And this is of course we only have 1 plane in the skin crease, and then make it a tunnel rounding in the orbital rim, and then we resection the frontalis muscle and suturing to the tarsal plate. But I have a difficulty when I got the 2 case with the deep set eye. It means the frontalis is protruded. That make it the factor of from the eye, the cornea, and the frontalis flap is too far, and then sometimes it make it the eyelids not in the good position. That can make it the entropion or something else. But when I try to find another college, make it the tunnel, they make it like an envelope. 1 minute more, please, sir. Sorry, sir. Yes, that's why I think in the frontalis flap we can make it a good position also for patient with the ptosis with a poor levator function. Thank you.